everyone. This is Mark Brownstein here. Welcome to my November 13th webinar. It's so nice to share this evening with you, and I truly hope that you gain a lot of information and insights in today's webinar. Interesting, on the top of the screen, it talks about this presentation also being delivered at Rockland Bosie's. This was a 2.5-hour presentation at Rockland Bosie's. So there's a lot of content here. My goal will be to cover this in an hour and a half, but certainly every situation of everyone who's on this call, your situation is a little different. The commitment that we have as a team at Emerald Medicare is to understand your needs, to listen to your needs, to be objective in our assistance to you, but really to provide education. To me, education is the driving force of Medicare. There's a lot of hype. There's a lot of information coming into your mailbox. Maybe you're getting phone calls, and maybe you're talking to some of your friends and neighbors. But this is a very unique season we are in of open enrollment heading into 2025. All people who do what we do here at Emerald Medicare are absolutely overwhelmed by the activity, the volume. But for us, it's important for all of you to understand that we do our best to help every one of you in a time frame that we can manage. We are working 7 days a week as a team to manage the workflow that we have. Many of you have spoken to me on the phone and have gotten to know me and the team. And there are many of you on this call who have never met me, and this is your first opportunity to meet me, to hear me, to listen to some of my knowledge about Medicare. But I take pride in the work that I do and we do. But there is no one in the industry who is doing a presentation like you're going to see this evening. No one. The amount of time it's taken to do this PowerPoint presentation would, I believe, surprise all of you. The attention to the facts and to make sure that we continue to present what is important in this industry. I personally am inspired to teach people about Medicare. It gets me up every morning. But it's important for you all to have patience through this very unique time of the year, also this unique season heading into 2025. The Inflation Reduction Act has created a tremendous amount of change in the industry. There are plans that are going away, being replaced by other plans. There's consolidation in the industry that is going on that is causing a lot of people's plans to go away, and they need guidance. They need to understand why certain carriers are consolidating. They're not going away. They're just truly looking at their profitability. And with the changes in the Inflation Reduction Act, there's a tremendous amount of anxiety by the carriers, and thereby you as beneficiaries, and by default, us as brokers and an agency supporting you to make sure that you get what you need going into 2025. We hope that you have trust in Emerald Medicare. We hope that you continue to have trust in Emerald Medicare. We want you to be clients of ours for years to come. And for us, these presentations, these webinars, a year and a half ago, I had a wonderful client appreciation event. Many of you were there because we really care about our clients. But the industry is changing, and my goal here is to share with you information that hopefully will help you, your friends, your neighbors, financial planners, CPAs, social workers, case managers, veterans. We want to help and educate all of you all the time. So I'm going to start this presentation, but I really wanted to give a little bit of background on why I'm doing this and how important it is to me to provide this education to all of you on an ongoing basis. I do about 40 seminars and webinars a year to all different groups and associations. If anyone knows anyone who would like to hear me speak, I'm happy to do it. I was in a church today for 40 or so seniors, and it was just lovely. And so this is what I love to do, and our staff does a tremendous job. So let me start with the presentation. So I've built my career in healthcare. I've been 30 plus years in the industry. I ran a software implementation company. I had a staff of 32. We traveled the country implementing healthcare software systems. But I'm an advisor to individuals in medical offices and financial planners and CPAs and HR professionals because they need this guidance and they need somebody who's objective, independent, and our services are no cost. And so people really appreciate that. We get paid by the insurance company, so all calls to us are no charge. I served as the president of the Financial Planning Association of Hudson Valley and a board member of FPA Connecticut. I've been very involved in the FPA CPA group. I've been involved with case managers and social workers. But this continual education, I've done easily 4,000 seniors and 2,000 trusted healthcare and financial advisors. I'm a sole independent resource for the local healthcare system. I have a radio show where I bring in guests who also support seniors. But I'm very active in my community. I love where I live, but I support the community and I do my best every day to give back. But people are shouting from the rooftops with a bullhorn. They are asking about Part A and Part B and special enrollments and advantage plans and home health care. And some of you, initially, some of this may be a repeat, but I feel like there's enough different people in here that I want to cover some of the basics as well. Healthcare costs are important, especially as people retire. Healthcare costs and the importance of it from a financial planning perspective for retirees is one of the highest costs that there is. Certainly dental concerns, and I'll talk about that a lot later. It's also important. People ask about it in almost every single phone call that I have. Some statistics I'd like to share with you. The average cost of healthcare in America is around $11,000 per year per person. And that's, of course, an average. But $4.5 trillion is spent on healthcare in the United States, eclipsing the gross domestic product of many third world countries. 50% of all medical costs in America are pre-diabetic insulin care or medications. That's a significant comment and affects a lot of the healthcare carriers' decisions on costs and profitability. Poverty or racism account for about 60% of all healthcare costs. Again, keeping those individuals with healthy outcomes is really critical to lowering healthcare costs. 63% of people over 65 really do consider healthcare to be their number one concern. But existing enrollees and new enrollees into Medicare really worry that they will get this important Medicare decision wrong, and that's why we're here. Housing is a big cost for people of all ages, but the spending of it is very high on the list for housing, but healthcare is up there as well. So seniors spend a lot more in healthcare than they do when they are under 65. Social Security and Medicare increases. Social Security increases have averaged about 2.3% over the last 30 years. For Medicare Part B, the premiums that you pay, whether it be out of your Social Security check or out of your pocket, is increasing about 5% a year. So people always talk about the Social Security increases, but not always about the Medicare Part B increases. But I always say health insurance is the same for everyone and different for everyone. But as you approach 65 or retirement, it really brings healthcare costs into focus because people are really looking at what kind of coverage do they have, did they have when they were working, and what is being offered to them in retirement. And how do we compare those two? It's by looking at the benefit summary. So one has to look at the premium costs as an employee, as a spouse. Are there children on the plan? Are there any substantial savings? Spoke to an individual today, $1,400 a month he's paying in healthcare costs. He's going down to, again, 400 or 500, depending on an income adjustment. So a tremendous savings for some, and some cases not for others. But one has to look at their utilization. How often are they using their coverage now? How are they paying for copays, deductibles, and most importantly, out-of-pocket maximums? What is that number? And do you get anywhere near close to that number for anyone on coverage currently? But in this transition to retirement, how does one look at Medicare enrollment? What is the timing of it? And how does one feel comfortable in making this transition so that there's no gap in coverage? So you do it in enough time so that you feel comfortable that everything is in place when you actually lose your group coverage. But these supplemental plans, these Medigap plans, these Advantage plans, they vary by state and sometimes even by county. So it's important to realize that there are variations and, of course, lots of changes going forward. Each year, though, and this is the time of the year, one really needs to evaluate, to really look at what's the best fit for their current budget and current health. So there have been changes over the years, more this year, but certainly over the years. In 2023, it was implemented an insulin cost cap. And so for most insulin medications, now almost all of them, it was capped at $35 a month. Again, back to a previous slide, a lot of cost for Medicare is in this area. So they've reduced the out-of-pocket costs for the individual. So it makes it more affordable to manage the diabetes. The recommended vaccines, eliminating the out-of-pocket costs recommended by the government, including shingles and pneumonia vaccines under the Part D coverage. Again, a change for 2023. For 2024, the eligibility for what's called extra help, which is the ability based on income and resources to save money for low-income beneficiaries to receive that assistance with the premiums, deductibles, and co-payments for prescription drugs. So it allowed more people to qualify. Also in 2024, and a big part of this conversation is about negotiated drug prices. The negotiations to reduce 10 of the most expensive drugs were targeted, and more coming in 2026. Many of the ones that people are asking about all the time are not coming till 2026, but there is progress, and that's what's important. So a couple of basics here. Original Medicare. Is it automatic? The answer is yes and no. If you're collecting Social Security at age 65, you're automatically getting your Part A and Part B card. So, but Part B is optional and you can decline it. If you don't decline it, the government will take out the money from your Social Security check. But if you're working for a company of larger than 20 employees, again, it's still based on some individual conversations, but in most cases, people would reject Part B. The other point to make is about Part A, is that people have what's called a health savings account, an HSA. These HSAs, people really like having them. They can contribute quite a bit of money and they can use it for many different things within healthcare. If you have Part A, one is supposed to stop contributing to their HSA. So that's an important part of our conversations here is, do you have an HSA? If you do, one needs to decide if one wants to go into Medicare but one needs to stop contributing to that. But again, if one does have Part A and one gets the Part A and Part B card, you don't need Part B. You need to sign the back of the Medicare card, return it back to the Medicare office, and then get a Part A only card. Part A only is premium free and is hospitalization only. Part B is all the doctors, the specialists, the x-rays, the diagnostics. If you're not collecting Social Security at age 65, it's not automatic. 75% of the people do apply for Part A, I will say. But signing up for Part B is really based on lots of factors. A big part of my conversations with prospects and clients is, what do you want to do relative to comparing your current plan to Medicare? But if you are a company of less than 20 employees, unemployed or self-employed, you must get Part A and B. Again, unemployed, self-employed, or working for a company of less than 20 employees. That's the critical number that people need to be aware of. But Original Medicare, people know of Original Medicare. They know Part A and Part B. Part A is the inpatient hospital, the skilled nursing, hospice, but it's generally premium free. Someone came up to me today, they had 7 years of working in America, not quite 10. They can buy into Part A. Then they still need the rest of it, but they can buy into it. There are people who come from other countries who want Medicare, but they have to buy into Part A if they don't have 10 years. If someone has 10 years and their spouse doesn't, then that's still okay. So it's either the individual or the spouse having worked 10 years or 40 quarters. Part A is premium free. Part B, on the other hand, is again, all of the doctors and the specialists, durable medical equipment, some of the dementia prevention services. These are Part B, and there's a premium to Part B. And the baseline, and I'll talk about it more in a little bit, the baseline is $174.70, and it's going to inch up a little bit in 2025. A and B covers 80% coverage, but does not include drug coverage. So that is something that one would need to add in addition to this Original Medicare. But Original Medicare doesn't cover everything. Again, a surprise for people. Some of the Advantage plans that are out there do. So routine dental care, 24-hour care, custodial, nutritional supplements, acupuncture, hearing aids, homemaking. Original Medicare doesn't cover it. I'll talk later on in the presentation about some aspects of Medicare that are changing relative to some of these areas. The enrollment periods, this 7-month window, it really applies to people who are unemployed, self-employed, or working for a company of less than 20 employees. But it's the 3 months before your birthday, the month of your birthday, and 3 months after your birthday. That's when people start to get antsy and really want to start to talk about, what should I do? Do I need Part A? Do I need Part B? But people who are working for a company of less than 20 employees, again, unemployed or self-employed, must do something during their initial enrollment period. The annual enrollment period is the period we're in right now, October 15th through December 7th. It's essentially 55 days or so. It's a sprint. There is no question that this time of the year is a tremendous challenge for you as clients or potential clients, for us as agents and brokers. But to say it very nicely, this is the time of the year when everyone is inundated in this industry and everyone's trying to help as many people as possible. And so I again speak of patience during this time of the year, because as you who have been clients of ours for a long time know, we get it done. By the time Thanksgiving comes, it may seem like we're almost done, but we know how much work needs to be done from Thanksgiving through December 7th. Open enrollment period is a very unique time. It is the time that you can actually yet still make a change that people are often not aware of. So this is a period of time between January 1st and March 31st, where if someone has an Advantage plan, they can actually switch to another Advantage plan if, in fact, they find out that their doctors are not covered for whatever reason when they walk into the doctor's office. They can also change back to original Medicare and a supplement and a prescription drug plan if they choose to. Um, but you can't change your prescription drug plan during that period of time. So it doesn't have all the flexibility that one would like, but it is still a chance for people to make some sort of change in the first 3 months of the year. Special enrollment. The special enrollment period really exists for those folks who are working for a company of greater than 20 employees, who are just putting off going on to Medicare because they're still working and they're still getting benefits from their company. Um, People wonder about whether I have to do it at a certain time of the year because my policy is renewing, my plan is renewing at my company. You have that special enrollment anytime you retire or get laid off. You can actually move over to Medicare. I always say, call me when you give notice so that we can make this transition smooth and quick. It takes about 3 weeks, 4 weeks to get your Medicare card. But if you have Part A, we can get you Part B and some kind of additional coverage in about 2 weeks or so. But that's one special enrollment, is what's called losing employer health group coverage. But there's other special enrollments. There's folks who are moving out of the county. There's folks that actually have not been able to, who have been able to take advantage of things like low income subsidy. People who are moving in and out of assisted living facilities in some states into a rehab facility. There's also FEMA-related special enrollments, hurricanes, flood, all those things that have been going on in this country. There's a lot of special enrollments that exist that we can often help people with during times of the year when they actually are looking to make an important change. So to keep it simple, there really are 4 choices once you have Medicare. You can either stay on your employer group plan, but before you decide whether you stay or leave your employer group plan, it's important to review the benefits. I do this all the time. I'm looking at the summary, I'm looking at the copays, deductibles, coinsurance, out-of-pocket maximums. I'm wanting to make sure that you understand your plan, how much the plan is costing you, whether it's being maybe subsidized, maybe it's part of a buyout package. Um, it's important to look at the plan because in many cases you can't get it back. So if it's a wash and it's similar, keeping the employer group plan is often what I direct people to. And I often direct people to stay with their plans because if it's the same or better, then it's certainly worthy. Original Medicare, on the other hand, as I mentioned earlier, is, 80% of all everything is covered, but there's a 20% exposure. So it's a little risky. But the reason why people like Original Medicare is because 95% of all doctors in America take Original Medicare. So that gives people who are in good health the confidence they can go anywhere they want. But it has the exposure. And again, there's no prescription drug coverage here, but you would need to add that. The Advantage plans, these are PPOs, HMOs, low premium, $0 premium, maybe $25 a month premium. These are managed care plans. They include and are embedded in it the drug plan. You still pay your copays for the drugs, but you're not paying an additional premium for it. On the PPO side, you can go in and out of network, though most people really do stay in their network. We see this all the time. But the HMOs actually give you a little bit extra benefits. And in these days of transition in what's going on in the industry, HMOs are actually giving a little stronger benefit because the PPOs are giving you that out-of-network access. Um, so that's MedAdvantage plans. They have some dental, they have some vision, they have some hearing. Some of them have over the counter. Some of them give you a little bit of payback for Part B. These Advantage plans work for many people. And I just want to tell you a little story. And that is I was talking to someone recently who was very biased against Advantage plans. And this person was a trusted advisor to a lot of clients. And they had said that they really didn't like Advantage plans at all. And I sort of was curious about that because even though there are some disadvantages to this Advantage plan model, there are many, many people who have the Advantage plans. And I don't think it's right or fair to actually put them down completely until people fully understand what people can afford, and what's right for them. And so I think that Advantage plans are growing in their popularity. I think the carriers are trying their best to give the benefits that are out there that they can offer. But they also shouldn't be completely discounted because they have value. And what people are concerned about is often not having some procedures covered, or they have to advocate for themselves. And that could be, honestly, with any coverage anywhere. Probably one of the biggest disadvantages is that in many cases, rehab is limited to 20 days. But my point is that I think that Advantage plans need to be considered as an option because your friends and your neighbors may have an Advantage plan. And you don't want to make them feel like they're in absolutely the wrong plan because they may not be able to afford option number 4. Option number 4 is these supplemental plans, also called Medigap. These plans, depending on the country that you live, could go from $75 a month up to over $400 a month. Huge difference. But yes, they are original Medicare. 95% of all doctors in America cover it. Um, it does not include a prescription drug plan, so one needs to add an additional prescription drug plan to that. In certain parts of the country, prescription drug plans are higher than others. And in these days of prescription drug changes, some of these prescription drugs, which I'll cover later, are way over $100 a month. On the Advantage side, you're not paying anything additional for the prescription drug plan, though you still are paying for the copays. So my belief and my education that I provide for almost every phone call I have is to make sure people understand the difference between Advantage and supplemental plans. Again, any doctor that takes Medicare anywhere in the country will take these Medigap plans. So it certainly offers peace of mind. But if somebody has an employer group plan, one needs to really look at these employer-sponsored plans. How much are you coming out of pocket for yourself or your spouse, or are there kids on the plan? Is it more cost-effective or not? Sometimes it's stay the course till you retire. In other cases, maybe the spouse is paying a lot more for the coverage because they're not the employee. So what's best, short or long term? Maybe one person is actually reaching that out-of-pocket maximum and Medicare becomes more beneficial. So if somebody is actually working past the age of 65 and they want to go on to Medicare, they can. And this is one of the forms that needs to be filled out. It's a form that the HR or benefits department will fill out, and it's a very simple form. It basically addresses having credible coverage so that you can actually get Medicare Part B without any kind of a penalty. This is one of the forms that we fax over to the Social Security office for you in addition to this form. This assumes you have Medicare Part A, and you're basically filling this out in the remarks section. You're basically putting in the fact that you request a Part B effective date of, let's just call it March 1st. And that's what we're putting in the remarks section for Part B. So this is an income adjustment to Part B. So this is currently the chart for 2024. This is again going to slightly increase. All of these numbers will slightly increase for 2025. So as a single person under 103,000, as a married filing jointly under 206, and this is adjusted gross income. Really, it's modified adjusted gross income. It's line 11 off of the federal tax return. But these are the costs for Part B or Part D that one needs to look at. And so these numbers have a small bracket. And so people in their retirement years or pre-retirement are sometimes making some decent money, and they have to know that this is part of their decision process. If somebody's on a group plan and they want to move over to Medicare, they need to consider the fact that Part B is going to cost them possibly more than the 174.70, and so that might change their decision on whether they actually go into Medicare or not. And we completely are authentic and sharing all the information that's needed in order to make the best possible decision. But there's good news, is that if one is retiring, or if there's divorce or death of a spouse, then one can fill out this life-changing event form. This life-changing event form is an estimate of current year's money, current year's income. So if one is retiring and one's income is dropping for, let's say, from April 1st through the rest of the year, then they can estimate the best they can the 2025 income so that they can get their Part B and Part D income adjustment reduced. So back to this, if they can drop it one bracket or two in retirement by filling out this form, they've just saved themselves and their spouse a lot of money. So Advantage plans, a bundle. It's managed care. They vary greatly by county. The maximum out of pocket for 2024 is $8,850. It's going up to over $9,000 in 2025. But they offer these other additional benefits: dental, vision, hearing, gym membership, over the counter. These are the things that are being offered. These plans are network based, so one has to truly look at the network that they're in and make sure that their doctors are covered. Sometimes we actually have to call the facility itself and ask them, because sometimes the portals are incorrect. Yes, you can go on and go to the carriers' portals and find out, but we find they're not 100% accurate. But again, healthy boomers without chronic conditions, certainly consider it. I don't know from what state some of you are calling in from. It could be anywhere in the country, and I hope it is. But there are 4 states where one can have an Advantage plan and move over to a Medigap plan without any health questions or underwriting. And that's New York, Connecticut, Massachusetts, and Maine. So starting out with an Advantage plan, that's the one area that I make sure I explain to people, is that if they're in an Advantage plan and then 5 years later they call, they may not get accepted in the Medigap plan. So that's just a part of what people sort of need to realize. PPO and HMO, these are the differences here, is that the PPO allows you to go out of network. The HMO is you have a primary care doctor and you're in a network. There are lower copays often in HMO, and there's often lower premium. But they both can have dental and hearing, prescriptions, eyewear, and they're all affordable. But there is a difference between an HMO and PPO. What we find is that even though people seem to lean towards a PPO, they tend to not go very much outside the network. This is the work we do as a company. We have a great team of people here. we're looking at the doctors and we're looking at whether they're in network or not. This is just an example. Different carriers, they change who's in their network each and every year, but this is our process. We go to the portal, we check it out, we create a spreadsheet for each and every one of you who are looking at an Advantage plan. Those who are looking at a Medigap plan and have stated clearly they don't want an Advantage plan, we do not need to do this because 95% of all doctors take the original Medicare. So these Advantage plans, this is 2025. So of the plans that are out there, these are reports that come from Medicare.gov. We use it every single day. We're a big fan of it, and about 30% of all Medicare beneficiaries actually feel comfortable enough going into Medicare.gov and doing some of the same research. But you can see the check marks and the X marks. The check marks indicate that this is some coverage that exists. The X marks means that this is not coverage that exists. You can see below the name of the plan is the premium. You can see that the AARP plan is now $25 a month. Last year, it was $0. And so United Healthcare has done a bunch of consolidation. They have had many more plans than this. This is now their only plan in this particular region, one particular region. And so this is the plan that one has an opportunity to utilize. Cigna is a new carrier to town. You can see they have an annual deductible of $500. That's for all services. The Aetna premium and the Cigna premium, you can see is $0 premium. The drug deductible is on the Aetna plan $590. On the Cigna plan, it's $0. The annual deductible on the Aetna plan really is hospitalization and surgery, as opposed to the Cigna plan, which is all medical coverage. So again, on the Elite plan, very popular plan, it's ambulatory surgical, it's skilled nursing, it's inpatient hospital. So again, these are Advantage plan choices that exist. But for us, it's about running the doctors, running the meds, and looking at the prices and how it impacts you. So this is United Healthcare's plan with a little bit more detail. Premium of $25, out-of-pocket maximum of $9,350. Okay, you can see that under skilled nursing, $0 copay for the first 20 days. And then from days 21 to 100, it's $203 as a copay. The differences in many of these plans are primary care and specialist. So you can see on the PCP specialist, in this case, there's tier 1 and tier 2. So a PCP being $0 and under tier 1 and tier 2, meaning that there are different tiered facilities for United Healthcare. This is a PPO. And so these are some of the subtle differences on the tiers. Other plans don't have tiers. United Healthcare has a local, has a regional, and a national plan. So it's all very tricky. This is the Aetna plan, okay? So there are 3 plans now. There's a $0 premium up top, the Elite plan. There's a $49 plan and a $46 plan. There's HMOs and PPOs. You can see that under more than halfway down, the primary care is either 0 or 5. The specialist is 35 or 40. And other things like emergency care are listed. In this case, you have the $1,000 for hospitalization and surgery, but you also have outpatient for $35 to $395 for outpatient hospital. That's a wide range, but all of them have that kind of range. Some of them are actually moving to a percentage. So instead of having a $35 to $395 range, they could say 10% or 20%. So all of these carriers are looking at utilization, and they're looking to make sure that they don't lose money heading into 2025. These are the subtle differences that occur. For those of you who are on any kind of plan, but most importantly, Advantage plans and prescription drug plans, you should have gotten what's called an annual notice of change. That annual notice of change is required by the carrier to be sent to you to talk about any changes that are going on, and they all have at least a change. So everyone should have received an annual notice of change, but many people have not or didn't really notice it. But that's why people call us to get the kind of guidance so that they understand what's changed and whether they should stay the course or whether we're really looking at all options all over again. I'll tell you that for many of you who may be on this Aetna Elite plan in various states, it is one of the most stable plans that we are currently working with. Very few changes to this plan, a subtle change to the dental coverage, but mostly this plan has stayed incredibly stable, and people have been very satisfied with this plan. And that's an important thing to hear. So just a little bit more on the Aetna plan. X-rays, $35. Again, diagnostic, $200 to $300. Preventative dental, $0 for preventative. Eyeglasses or contacts, $200 every year. Routine hearing exams. And then there's a copay for hearing aids based on whether you want good, better, best hearing aids. And then there's copays for things like physical and occupational therapy. So you can see some of this detail is very helpful. People do like to review these things to get a better understanding. But folks, they're not perfect. These plans are not, for everyone. And every year, that's why people review them. So some of the oversight changes that are going on. Med Advantage plans, as I've said earlier, have come under criticism for the deceptive marketing. But there's also been wasteful overpayments by Medicare on both the Advantage side and on the Medigap side. But CMS, which is the Center for Medicare and Medicaid Services, really, they released a ruling that would increase the oversight, which addresses things like gaps in mental health, which I will talk about, reviews of the Advantage plan denials. Again, one of the areas that people are concerned about is to the extent to which denials are becoming a challenge. And that is an oversight issue that they are trying to take on and improve upon. The marketing practices, you all see the TV ads, you all see what they're saying, everything's free. And so those are somewhat deceptive, and people are often going on the internet, many cases getting scammed, but also people are believing in many cases that they're getting these extra benefits when in fact their doctors aren't covered. And so one needs to look at the whole picture to really make a good decision. Again, based on the part of the country that you live, there are many different carriers that are offering Advantage plans, but there's a lot of turnover. But when you find a stable carrier, I can say it's worth sticking with. So some of these marketing rules, right, are to essentially reduce the number of phone calls that people get. They mislead viewers into thinking they're being contacted by a government agency. Some of these benefits are just not available in people's viewing area. And so that is a regulation that has been implemented. In 2026, they are looking to reduce the response time for prior authorizations within 7 calendar days, shortened from 14 days. That's a lot of time to wait, even 14 days, even 7. But they've halved it, and that's, again, prior authorization for Med Advantage plans. And so also they are evaluating how these prior authorizations are affecting some of these vulnerable populations So they are trying hard to address this. The other component of these Advantage plans is they're looking at mid-year notifications. Some of you have Advantage plans. I know that. I recognize some of your names. These plans offer dental, they offer eyeglasses, they offer some extra healthcare related activity. Many people don't take advantage of it. We sent out an email about a month and a half ago to encourage some of the users of some of these plans to take advantage of some of these benefits because in some cases they're going away. And we wanted to let people know that we are letting them know. Well, the truth is that in 2025, CMS is requiring a mid-year notification of unused benefits. Now, the challenge is that carriers count on the fact that people aren't going to be using it. And so they actually get paid more money by the government to add these benefits. Now they're being required to let people know that they haven't taken advantage of that. And they are encouraging people to use the unused funds, unused benefits, because the money that they get for this to give benefits is being redirected to marketing efforts, in some cases, marketing efforts that are deceptive. So other changes, dental coverage. Some of these plans are reducing dental coverage. They're not taking away. This is a part of coverage that can't go away. But in many cases, they're reducing it to a lower number. Again, not enough people use them, but they're also having preventative care only. Some of the plans have comprehensive care. Comprehensive care includes things like root canals, crowns, extractions. That's not considered preventative. So supplemental plans. This is the simplest, higher cost, most freedom, standard national coverage, and easy to understand. It's the preferred choice for the more affluent consumers where premiums aren't an issue. There's plan N and G and F, and there's a high deductible plan. The high deductible plan has a $2,800 out-of-pocket maximum. And depending on where you are, the price of that could be $70, $80, $90 a month in areas where the plan N and G could be double or 3 times that. So premiums range a lot across the country, but they're standard. A plan N in New York is the same as a plan N in Florida or Texas. They are the identical coverage from one carrier to the other. What's different is the price. And what's different is renewal rates over time. So one of the things that we're very conscious of, especially in these years of big change, is to look at the average over, let's say, the last 5 or 10 years to see how carriers have increased their prices so that people understand that in many cases, carriers will come into a market, do what I call a bait and switch. They'll get you in at a somewhat lower rate, and then 3 to 5 years later, they'll raise the prices significantly. And in states where you have to go through medical underwriting in order to apply for a new supplemental plan, you may not get accepted. Star rating is customer service. I'll explain that in a little bit as well. But people like these supplemental plans because you can go to any doctor anywhere in the country that takes Medicare. Maximum flexibility, minimal friction, but there's no drug coverage. So you need to add that in addition to it. Prescription drug plans, the single biggest change that is going on in the industry, and it's causing all the havoc that we're seeing, and it's causing a lot of upstream and downstream impact by the carriers and by each of you individually. But for the Advantage plans, there's no additional cost. The standalone premiums have changed. In some cases, they've gone up dramatically. There is one carrier, happens to be in the New York area, that went from $3.70 for a monthly premium up to $37 per month. Well, they did what I would call a bait and switch. They got people in under a low premium, and then they raised it tremendously. But in New York, it's still the lowest premium plan. Um, Now their customer service isn't particularly wonderful, but there isn't any lower option. Over the last 5 years, there have been a number of carriers that have come and gone, and a number of carriers who have just simply cut commissions to the brokers. And there's just a whole lot of challenges and changes. There are many people who do what we do as brokers who do not do prescription drug plan reviews because it is a lot of work. There's really very little, if not no money to be made in there. But for us, it is critical for retention of you as a client, for potential referrals to people you may know. But it's also a very core component of your coverage. We know that. We believe in that, and we are committed to helping you through this. But again, be patient with us. We are up to over 500 prescription drug runs currently. And as I said earlier, we will get them done. And we are working tirelessly to do that. But 2024 had 4 stages of coverage: the deductible, after the deductible, the coverage gap, which was the donut hole, and the catastrophic of 8,000 for 2024. Now it's $2,000 maximum for 2025. That is a huge difference and is the cause of most of the changes that I have said up until this point and will say as we proceed through this webinar. So the tiers keep changing, the formulary keeps changing. Again, another annual notice of change that you've received has been about your prescription drug plan coverages. Prices have always changed yearly, folks. This is not new, but the dramatic change from catastrophic, from 8,000 to 2,000, eliminating the donut hole, is a huge change, and the impact is yet to be seen and will start to be seen starting January of 2025. But one thing that people often don't realize is that there is often a big difference in utilizing a preferred pharmacy or standard pharmacy or mail order. And, it's very real that independent pharmacies are having a hard time these days. Even Walgreens are closing because of this prescription drug model that is changing the industry. It's nice that the government is now negotiating, but now the carriers are actually having an impact on the way in which all Medicare is being priced. But there is discount options. There's GoodRx. There's Single Care. Mark Cuban has something out there. Amazon has something out there. And then there are pharmaceutical grants that are out there that people who have very expensive medications, in some cases based on income, in some cases just based on need, they can actually get a grant to cover some of the expenses that are incurred. There are people who we're talking to who say, I don't want a prescription drug plan and I'll just get it from GoodRx. We'll just take generics. We don't ever recommend that because we don't think anyone should ever pay retail. Again, we understand the high cost of prescription drugs, but that's why people are looking at Advantage plans differently because there's no Part D premium. On the other hand, if one doesn't have a Part D plan and years later says, I need one now, there is a penalty that occurs for not having coverage, for having a gap in coverage. So the formularies have changed for both standalone plans and Med Advantage plans. The liability for the drug manufacturers have increased from 20% to nearly 60%. The impact is tremendous. This $2,000 limit, the carriers are assuming some of this liability. And that's really impacting their decisions across the board. They don't know what 2025 is going to look like. It will take through 2026 before all of this flushes out, especially since there are a whole lot more medications that are being put on the reduced price list in 2026 than 2025. But the good news for many people is that there's a payment plan that's being introduced, which means that if you have the maximum 2,000, or even if you have $1,000 worth of medications through the year, you can spread it out over a 12-month period. So you can actually call your carrier and say, I want to set up a payment plan. Each time you get a new medication, they will recalculate that monthly charge, but you can put it on a payment plan. So for those of you who are on this, who understand that the beginning of the year with the deductible, you can pay a lot more in the first 2 months, and then it changes based on the coverage gap and the donut hole. But now there's a payment plan that's being introduced. We have read all we can about this. We do not know how it's going to be implemented. Again, the carriers are concerned about bad debt. But this is what's being offered, and this is a huge opportunity for people who are on somewhat expensive medications. But if any of you have seen some of the reports on things like Wegovy, Manjaro, those kinds of medications, why is the cost of those medications so high in America? Why are so many medications so much cheaper elsewhere? Is the PDMs are impacting the marketplace in a big way. Again, 60 Minutes did a report on it. It is very real. Independent pharmacies are feeling the hit even more than anyone else. But there are many Walgreens places that are closing down. A lot has to do with the cost of medications and the middlemen, which are the PBMs. Many of you have WellCare as a standalone plan. In many parts of the country, it's still the lowest. But even though they are the lowest, it's not necessarily true that their formulary is the same as last year. It's also not particularly wonderful customer service. So there are other carriers that we are helping guide people towards. But of course, this is what's right for you, and we will help you in every way we can. So I mentioned these resources earlier, but GoodRx is one. The Canadian store, which is actually a Florida-based company, also has medications at competitive prices. Mark Cuban's Cost Plus Drugs is affordable medicine, usually generics. Amazon as well. These are online pharmacies that do not go towards your Part D. So if you go through those plans or those companies, you're not getting the discounts that you would get because of the 3 stages of pricing that occur, no longer 4, 3 stages of pricing that occur within Medicare. And then there's a nonprofit organization called Needy Meds. This really provides free information for assistance programs for the particular medications, and often the pharmaceutical company that's involved in this. So those are pricing resources. So here we have cost for 2025 for standalone prescription drug plans. We talked about WellCare. Cigna is an American-based company. They're just a few dollars more. And then there's SilverScript. You can see from the pricing that this is all in. So you can see SilverScript, even at $66, the cost at these pharmacies are much higher. And the difference between Cigna and WellCare in many cases is really the $3 or so of the premium. But you can see that there's preferred and there's in-network. So a preferred pharmacy is going to be a lower priced. Yes, in many cases, mail order is better priced, but these are, this is what we do. This is what we run, and this is when we're talking to you over the phone, guiding you. We are giving you the best advice we can based on the information and the meds that you're sharing. We have a fillable worksheet for both actually doctors and meds, but it really, it's about us knowing exactly what your meds are, the frequency of them, and the dosage. In some cases, people take them only as needed, and some people will renew it every 2 months. Spoke to someone today who takes half of one, so it's really renewing every 2 months. At the end of the year, we're always looking at whether people have a stash of medications to last them for the year before we actually look at the new pricing for the new year. So all of these things are all important. So this is 2024. You can see that there are zero premium plans, and you can see that the prices have jumped. The Cigna Saver went up, the WellCare went up, SilverScript went up as well. But again, their formularies have changed. But that's part of what we're sharing with information. So the Inflation Reduction Act has, again, caused havoc in the Medigap plans, and many of you on this call are on Medigap plans, Med Supplement plans. The average rate of increase has been 4%, maybe 6%, but there are some places around the country that are seeing increases of 9 to 13%. So these prices depend, the timing of the changing of prices is based on a number of factors. Some are beginning of the year. In most cases, you hold your price, the price that you're given for 1 year from the time in which you start the plan. But there are plans that go up in the beginning of 2025, some are mid-year. And so each carrier and each state is a little different. So Aetna is expected to lose 10% of Advantage plans. But again, they're not going away. Aetna and United Healthcare are simply being smart. They are not sure what's going to happen. They're consolidating. And, people run for the hills sometimes when carriers exit a plan, but that doesn't mean it's bad news. It just means that someone needs to find another plan that fits their needs. If in fact all your doctors are covered by a particular carrier, in very many cases, that carrier is still going to work for you. It's just a different plan. So, I don't want people who may be on this call to panic about these two carriers. These are very strong carriers, but one needs to be proactive. We're reaching out to all the folks that we know that their plans are transitioning or the consolidation is going on. But, you may have friends who are not paying attention. So we encourage you to just let them know that there is a independent, no-cost resource that's out there. But carriers don't necessarily encourage you to use their benefits. And in many cases, there's not a lot of differentiation between some of these options, which is why the consolidation has occurred. But the carriers, I think you've heard me say this a number of times, they're wrestling with solvency and they're concerned about bad debt. And so that's making them all pretty nervous. So if we look at frequently asked questions, we look at dental and vision. We've covered some of that, we'll cover more, but what's the difference between Advantage and Supplement? And how will this new payment plan work? And will my Advantage plan change in 2025? The answer is probably yes. If I go to another state, if you have a Medigap plan, you can use it anywhere. If you use an Advantage plan, you can use it for a little while, but if you're moving, you need to change your plan based on zip code. Do I need to renew my coverage? Well, the answer is if you're happy with it, you can review it, but you don't need to actually do anything if the plan is still in force, if it still meets your needs. How often can I change it? Well, really, it's October 15th through December 7th. There's this OEP of the first 3 months of the year. And there are other special enrollments, but that's when you can actually begin this conversation in earnest. How do I find out if my medication is covered? Well, look at their formulary online, contact your carrier, or call us. Do I need a Part D plan? The answer is yes. So what are some of the other benefit trends? Well, gym membership has changed because of COVID. People are using Peloton, they're using home type fitness programs. And these are the three carriers that are out there. Renew Active with United Healthcare. Silver Sneakers is most of the others, but Silver and Fit has come into the marketplace. And they all have different gyms that they're associated with. And so any one of them has a website. You can type in your zip code. And for some people, gym memberships are very, very important, but so are doctors and so are medications. There are some gyms that are covered under Renew Active that have all of a sudden implemented to use all of their facilities. They've implemented a $20 extra cost, even though the utilization of the gym equipment may be free to use the classes. In some cases, they've restricted the hours that people can use the gym to seniors. In some cases, there's a waiting list. So these plans are changing, but it's good to have a gym membership. I know that I use mine. So some of the consumer trends that are out there. 24% of all Medicare beneficiaries actually use Medicare.gov, and that's what we use. It's very reliable. 30% of all Medicare clients are hospitalized to some extent each year. Carriers want to avoid hospitalization at all costs, as it is the largest single expense. And they will do anything to reduce that. One of the things that I will cover is a little bit of home care coverage that's going on, because this way they can reduce hospitals. About 2.5 million enrollees pass away each year. 74% of Advantage beneficiaries are enrolled in a zero premium plan. They have copays, and they might pay for premium copays for their prescription drugs, but they are zero premium. But a Med Advantage plan that changes a premium or a copay by $5 may or may not have a big impact on consumers, but it certainly has a big impact on the insurance companies. 80% of people who enroll in Medicare for the first time do it without a broker. We're surprised by that. We believe that having a broker support you in the initial phases of this really helps you understand what your options are and gives you peace of mind. But again, many enrollees worry that they're going to get this decision wrong. I believe more people should use brokers and not call the insurance company. So how do we improve the Medicare landscape? They want to clean up the industry. They want to reduce the number of phone calls that come to the consumer. When you go on the internet and you log on and you ask for Medicare information, those leads are being sold to a half a dozen people, if not more. So they're trying to cut down the number of leads that are being sold when people go online. Reducing the unsolicited pieces of mail. People talk to me about barrelfuls of information. There's anti-competitive practices amongst carriers. There's frustration in the enrollment process. The number of choices and Advantage plans are too many because they're just too similar. They need to be simplified. Star ratings. Star ratings are important. Star ratings actually, and I'm looking at some notes on this. Star ratings are based on 44 measures, including staying healthy, managing chronic conditions, member experience, member complaints, drug plan customer service. The difference between a 3-star rating and a 3.5-star is millions of dollars for the carrier. They do everything they can to offer richer benefits, like lowering copays, including more vision or dental or transportation. So added benefits translate into higher growth and better member experiences, which increases their star ratings. And so the challenge in this is that these star ratings are announced in October. every year. So they just came out recently in anticipation of the open enrollment season. But this is actually a reflection of the performance of a year ago, before the rating was actually issued. So, low star ratings exists, but it's almost a year behind. And seniors don't really know the difference between a low star rated and a high star rated until they get sick. And it's too late to make a change. So, the spiral exists. They invest in more benefits to increase their ratings, to increase their profitabilities. On the other hand, if they slash benefits because of profitability, their star ratings go down. So star ratings are important. Reform is needed in this. There could be a phone call that you make to a carrier where you're complaining. That one call can swing a star rating more than you think. So that's the conversation on star ratings. Extra help and low income subsidy. These are programs that are out there that people who are on low income can help, even further help from prescription drug plans, and can help with deductibles and premiums that really do make a difference for a lot of people. Dental coverage. Dental coverage, for many people, it's critical or it's not essential. You can't be healthy without sound oral health. I talk about this all the time. I have on my website an entire dental webinar that any one of you can listen to. Coverage was introduced in 1960. The maximums, 1,000, 1,500, haven't changed much since then. But poor oral health affects physical and mental well-being. And dentists can often detect things like diabetes, cancer, heart disease, and dementia early. 1 in 6 adults have untreated tooth decay. 2/3 have gum disease. 1 in 5 adults delayed or skipped dental care in the last 2 years. 47% of adults have dental coverage at age 65 or above. Emergency room visits are preventable for oral, but they've surged. Many states also have excess dentists. They have capacity. The dental industry is still the Wild West. What people say they're going to go. 77% of the people say they're going to go to the dentist. Only 37% of the people do. And yes, it's really the cost is why people don't go. But it's expensive. There's a lot of out-of-pocket costs for dental. 1 in 5 beneficiary who used any dental services spent more than $1,000, 11% more than $2,000. Costs even for high income earners, cost is the number one reason that people don't go. There's in-house plans that dentists offer, but it's really only covering the basics: cleanings, x-rays, cavities. They might offer you a discount, but you're paying that $200 to $300 up front. If you're going to get 3 to 4 cleanings a year, they have to code it differently. They have to code it as if it's periodontal work, not just a regular cleaning, in order for you and they to get reimbursed. So Advantage plans don't offer the same dental coverage. Standalone plans itself vary a lot. We have a person internally who will help people look at standalone plans. The Advantage plans, they're all different. You can go in and out of the network in many of them, but their reimbursement rates are different. It's okay to ask your dentist for a cash discount, and your dentist can help control some of the expenses. How do they do that? They do that by saying, okay, let's do some in 2024 and some in 2025. But you need to expect to pay out of pocket for anything beyond preventative. People don't realize that it's really 50% coverage of anything beyond cleanings and x-rays and cavities. 50% out of your pocket. But 50% of $1,000 or $2,000 is better than nothing. And so I always encourage people to have some kind of dental coverage and use it. For people who have HSA money, I encourage people to use that as well for dental, and they can use it for as long as they have it. Talk to your dentist about what care is important. If you need expensive services, schedule them one year to the next. Don't skip dental visits. Okay, these are preventative and these are comprehensives. The ones on the right are comprehensive services. These are 50%. Some plans have a waiting period. Talk to someone today, have to wait a year in order to get some of the work that they need done that even covered at 50%. The nice thing about Advantage plans, folks, is that there's no waiting period. You can use it day one. For those of you who have dental coverage on your Advantage plan, you have a month and a half to use it. And then if you have dental coverage next year, you can use it again. So I really encourage people to use the benefits that they have before the end of the season because they may go away. Hearing. There's a lot of myths about hearing. Medicare doesn't cover hearing aids. They cover the exams if ordered by a physician, but not hearing aids. And hearing aids come in various price ranges. There's over-the-counter hearing aids, but it's really based on the hearing loss. But it really does improve health and the quality of life. Both dental and hearing are really important in today's over 65 market. The people who are taking care of that, they are more social, they're more active, they're not as isolated, which is why the carriers are looking at hearing coverage as a component to, again, improve people's social activity. Certainly coming out of COVID, there's a real need to increase people to get out there again. Regular hearing tests detect gradual loss. So most of the carriers, again, an audiologist is covered, but hearing aids improve. They amplify some sounds, but they don't restore natural healing. And so there's also comorbidity. There's depression and increased risk of falls. So it's important to look at hearing loss or hearing aids as something as we all get older. Dual special needs plans. These are plans with people on Medicare and Medicaid. People who have both of those often don't know that the carriers are offering some very extra benefits. They have over-the-counter. Sometimes they have help with utility bills and food and housing, but also they have a personal care team. They have somebody who's a care coordinator, a social worker, who's really looking out after. Again, this is about outcomes for people who are on this low income status. If the carriers can improve their health outcome, they don't use coverage as much, and it really saves money for all people who are utilizing healthcare, because then the carriers have more money to be able to offer benefits to the rest of the population of people. So just a quick comment about the Affordable Care Act. We don't actually sell it. I have a resource that does. I also have a resource that does, and I do a little bit of long-term care for those people who actually are in a lower asset bracket, who don't have a financial planner. There's also a model called Retirable, where people, even with just $50,000 worth of assets, can actually get some financial planning. So there's the Affordable Care Act, and based on the individual deductible or out-of-pocket maximum, I have a resource that can help with that as well. So there are other resources that are out there, but our company is really looking to help as many people as we can in as many areas as possible that's important to them. A couple of things that I'm 10 minutes away from the top of the hour, and I hope this has all been helpful, is that there is for Alzheimer's patients. Uh, there is at-home care, but only if homebound. Um, I just saw a wonderful movie play in Broadway called The Notebook, and it really addressed Alzheimer's. It was a very touching play, but certainly people with Alzheimer's, and there was a appeal at the end of the play for some donations, which was very sweet. But the services relating to Alzheimer's is becoming more important and more important to be at a home care level, because they're not going to be going, hopefully, anywhere but home, but they need care at home. And Medicare will cover some of it. There's home safety evaluations, there are cognitive assessments, and certainly with hospital stays. But there's more, is that home care is becoming more and more important. So whether it be physical therapy or speech therapy, durable medical equipment, up to 8 hours a day of part-time skilled nursing, there is home care that's available. But to receive Medicare coverage for a caregiver, the patient has to be enrolled in Medicare, the services have to be medically necessary, the caregiver has to meet Medicare requirements. There are programs, but in most cases, family members and friends are excluded. But the doctor needs to create the plan that explains how the caregiver will assist in the patient's health. But there's a new plan out there, and I'm very excited about this, is that this is an organization called Ruby Well, and they are paying family givers a living wage. So there is a lack of labor force out there, untapped, to be able to help people at home. And people at home want to help their loved ones, family members, but they often have to leave their job or take time off of work to help. And so what this program is doing is that it is a training program that allows people to go through 28 to 35 hours of training, because this is about not just improvement, but maintaining the patient's current condition, or preventing or slowing the further deterioration. There's a settlement called the Jimbo settlement that changes this belief significantly, that the Medicare program now can cover nursing and therapy services, where not just when they're expected to improve, but the maintenance of them and to prevent slow deterioration. This is a big area. And so there's a misconception that it can only be short-term and not long-term. And this was a settlement and a large lawsuit that occurred, that is now changing the industry. And I'm hopeful that this continues to get implemented. Part of it is about the people who want to get paid to do this have to go through some sort of training. And once they do, they can get paid. So training for caregivers, there's also that, where caregivers can get paid. There's new changes that CMS will pay for some of these family caregivers. And that includes training for groups of individuals by physicians, physician assistants, therapists. So these are the kinds of positive changes that Medicare is looking hard to implement. Again, because if you keep people at home and keep them out of the hospital, the carriers can impact their profitability and thereby giving more patients more benefits. These weight loss drugs are also going through a transition. Ozempic, Mounjaro, I talked about them earlier. In some ways is that the PBMs are charging too much money for them, even though with a $2,000 out-of-pocket maximum. Some of this is being approved, though, for not just overweight individuals, but also with cardiovascular disease. And so they couldn't change their Part D plans in 2024, but some of this is being adjusted in 2025. Again, this is still about the doctor submitting the right substantiation. So even Zepbound, being approved. They're looking at conditions like sleep apnea, which is very big in America, and not addressed by many people who have it. And it really does affect health as well. So there's all kinds of changes and research that's being done to really include more of these drugs. Um, and the manufacture of these drugs are just going crazy in terms of how much is being produced and how much demand there is. And in some cases, it's not as available. Last couple of slides here, folks. Mental health. They are looking to increase the number of mental health professionals that are available through Medicare. They're looking to bring on over 400,000 behavioral health clinicians nationwide to be eligible to serve under Medicare. They have to apply to be under Medicare, but they are increasing that. And that's important because many people, again, whether it be post-COVID or just in general, um, you know, really value that kind of mental health counseling. And so adding more professionals who are accepting Medicare would be really very valuable to many people that I work with. In many cases, currently, many therapists do not take Medicare at all. So if that changes, that's again another positive impact. Technology. Technology is coming, folks, and I can tell you that we are very much looking at that as well. When it comes to things like prescription drug runs, there may be a day sooner than you think where you can actually call up an AI component that's working with Emerald Medicare, where you can talk about your changes in your medications mid-year. You can ask about whether there's an alternative. Um, you can ask them questions about whether there's any kind of a step therapy or any kind of a approval process with specific prescription drugs. This is really important because as much as we do for our clients, the prescription drug market is really changing and people are very sensitive to information about this to maximize. We're not able to provide alternatives, but one can actually find out from their doctor from some guidance on what alternatives may be that is worthy of discussion. So AI is coming and we're evaluating it. And for those of you who are clients, expect to hear more about that in the coming months and the coming years. So review your options heading into 2025. Give us a call, send us an email. Again, we, like every other broker in this industry, we're overwhelmed. Please be kind to us. Please, we're not a commodity. We offer objective information, but we're inspired to help you. We know that this is important to you. I do my best to be a thought leader. We also really appreciate a nice Google review. It helps us grow. Tell your friends. Ask me to speak in front of a group of people. But if you have an annual notice of change, look at it. See if there are any changes to your current plan for the new year. Compare your plans as thoroughly as you'd like. Don't rely just on premiums. Lower premiums may mean higher out-of-pocket costs, fewer benefits, or not as good coverage for your medications. Look at deductibles, co-pays, costs, in-network providers. Review this. Take the time. Work with an independent broker who's not the insurance company who's trying to sell you on their particular plan. But we, like CMS, is focused on ethics and trust. We want you to trust us. We want you as clients for years and years to come. Focusing on the challenges and the opportunities, knowing that there's bad behavior in the Medicare business, we're implementing strategies every day to increase our value to you. If we don't get back to you right away, we are getting back to everybody through email and through voicemail. We know it's important. We've got more than a few weeks to go. We are, again, working 7 days a week. But it's important to have unbiased and have a relationship with your broker. We offer individualized support. We're unique in almost every way. We have a team of 7 who is devoted to you. Most of the people who do the work we do are individual single entrepreneurs. We are a team of people devoted to finding out what is your unique needs and the individual needs that you have. We're a trusted resource. We're ethical. We're transparent. We're going to review your costs. We're going to give you clear, objective, unbiased information, and our services are free. We provide other senior resources. I belong to many senior groups that have all kinds of senior related services. I'm on panels all the time, whether it be the Alzheimer's Association, Senior Law Day just recently occurred for 400 plus people in a county that I live in. I'm involved in everything that allows seniors to be supported in one way or another. But our mission is to support you in ways through expert guidance, through the tools and resources, through friendly, experienced, knowledgeable support. We're all about servicing. There's a lot of work that goes into the work that we do, and we hope that you appreciate it. We want you to be a part of our community, but recognize the importance of your costs and the integration with financial planning. Advocate and appeal. If you get a bill, don't necessarily pay it right away. If you're getting a service denied, don't necessarily take it as the final arbiter. Look for objective information. This is the open enrollment season, October 15th through December 7th. Review your doctors and medications. And again, find the trusted resource. I want to thank you. I've gone just a little over 8 o'clock. I know you've been in touch with Michelle. And again, give us a call, have patience, have faith in the team. We'll get it done, and we'll be here year after year to help you. I thank you so much for being a part of this webinar today. Please tell your friends and family. Be safe, be healthy, and have a good evening.